Hello, everyone, and welcome to FAIR's free webinar series. My name is Carrie Mulkowski, National Programs Manager at FAIR, and your moderator for today's presentation. Just a little bit of housekeeping before we get started. Content for this presentation was derived in part from questions we received from our food allergy families about the new NIH guidelines for introducing peanut to the infant diet. This presentation has been pre-recorded. Today's session will provide some background information about the 2017 updated guidelines from the National Institute of Allergy and Infectious Diseases regarding when and how to introduce peanut to the infant diet. Our speakers today are Ms. Maria Acebal and Dr. James Baker, who both served on the expert panel that developed the new guidelines. They will address questions FAIR has received from members of the food allergy community about the new guidelines. We hope you find their advice and answers valuable. Maria Acebal currently serves as a member of FAIR's Board of Directors and a member of the NIAID Advisory Council Allergy and Immunology Subcommittee. A food allergy mom, she is the former CEO of Food Allergy and Anaphylaxis Network, FAIR's legacy organization. Dr. James Baker is the CEO and Chief Medical Officer of FAIR. For 20 years, Dr. Baker was the chief of the Division of Allergy and Clinical Immunology at the University of Michigan, where he helped start the Food Allergy Research Center. Dr. Baker has more than 30 years of experience in basic biologic research, concentrating in immunology and host defense both at the University of Michigan and in industry at Merck, where he served as the Senior Vice President and the Global Head of Vaccines. He has authored more than 350 peer-reviewed scientific articles. At this time, I am delighted to turn the presentation over to them.
Well, it's a pleasure being able to talk about the guidelines because both Maria and I feel that they're important advances into how we approach young people with peanut allergy. I think it's important to understand the background and a bit of the history. When physicians first saw the rapid increase in peanut allergy in the 1990s, they felt they needed to do something. And the American Academy of Pediatrics in 2000 suggested that it might be a benefit to delay the introduction of peanuts into the diet of young people who might be at risk for peanut allergy. And in fact, for the most part, this was taken as a general way of dealing with all children. So people were avoiding to feed them allergenic foods. Then in 2008, there was actually an article in the Journal of Allergy and Clinical Immunology that suggested there were differences in peanut allergy in different countries based on whether or not young children were fed peanuts. In 2010, NIH cited the lack of hard evidence that delayed introduction of foods prevented allergy and suggested that more research was needed. And this assessment really, not much came from it initially. And pediatricians continued to tell patients not to eat foods. And part of that was because the challenges of these types of studies to evaluate the effect of things like early feeding. Maria?
So while these NIH guidelines talked about the lack of evidence to support delaying introduction of allergenic foods to infants, it didn't tell us anything about prevention. Prevention studies are notoriously difficult to fund and by their very nature take a long time to generate data. However, these lingering questions about early feeding could only be answered by a prevention study. And thankfully in 2008, in partnership with NIH, FAIR became one of the funders of the LEAP study, the Learning Early About Peanut Allergy study, the aim of which was to find definitive evidence-based strategy to try to prevent peanut allergy. The study was finally published in 2015. So if you look back, 2008 was when we started the funding. It took 7 years to get to publication of this prospective study of early peanut feeding.
The study was very interesting in that they did a prospective double-blind study, i.e., this was moving forward, actually identifying children early in their life and either feeding them or not feeding them and blinding both parents and physicians to what was being done. They looked at infants that were at high risk for peanut allergy and defined them as individuals that either had egg allergy and or eczema. And those are two risk factors for young people having peanut allergy. The infants with peanut allergy already by the 4th to 6th month of life, i.e. they had reacted clinically to peanut, were excluded from the study. But in fact, young people who reacted to peanut on skin test or blood test but weren't clinically allergic were included in the study. And they were basically two groups, the young people that avoided peanut, and then peanut that individuals that were given a defined amount of peanut every week from age 4 to 6 years. And by age 5, it was remarkable that when you look at the children who had eaten peanut regularly since about 4 to 6 months of life, 3.2% of them had peanut allergy. Whereas if you avoided peanut, 17.2% of the children had peanut allergy. So there was actually an 81% reduction in the amount of peanut allergy in the children that were eating peanut from age 4 to 6 months.
There were two follow-on studies that gave us a little bit more information after LEAP. The first one is the LEAP-ON study, the persistence of oral tolerance to peanut. The important question that this study answered is, what happens if these kids who had been eating peanut stopped eating peanut for a year? Would their tolerance against peanut allergy persist? That is, would they remain able to keep consuming peanut without developing allergy? And the answer to that was yes, that children who ate peanut regularly from infancy to age 5 in the LEAP study retained their protection against peanut allergy even after avoiding peanut for a year-long period between the age of 5 and 6. A second important study that answered a question about breastfeeding was the Inquiring About Tolerance study. In this study, we had two groups: infants that were fed allergenic foods early, that is before the age of 6 months, and infants that were exclusively breastfed. What we found here was that the rates of food allergy did not significantly differ between these two groups, so that early introduction did not lead to food allergy development.
One of the results of these studies was that NIH felt that they needed to readdress the issue about early feeding. So they convened an expert panel to address the findings of these studies and come up with recommendations about what to do with children feeding them highly allergic foods. And in June 2015, 26 members were assembled into an expert panel to try and evaluate an evidence-based consensus on what to do with early feeding of children. And this was a very diverse scientific and medical group with individuals from all walks of medical life, including dermatologists, allergists, and pediatricians.
So in 2017, the NIAID released addendum guidelines to their previous guidelines on food allergy diagnosis and management. And here, these addendums addressed prevention, and they were based on children's risk of developing peanut allergy. There were three categories of risk detailed. The first, high risk, are those infants who have egg allergy or severe eczema or both. So that would be infants that have clinical egg allergy and or severe eczema. That makes up the high risk group. The next risk category is moderate, and those would be infants who have mild to moderate eczema alone. And finally, the third group, the low risk group, are those infants that have neither food allergy nor eczema. One important thing to note before we get into the details of what the advice is for each of these risk categories, and that is we are going to be talking about feeding peanuts and peanut products to young infants, and it's very important to keep in mind that peanuts and peanut butter are choking hazards for infants. The guidelines offer a great appendix where they list several recipes of safe forms of peanuts to feed to infants. One of those recommendations, for example, is pureed fruits or vegetables with 2 teaspoons of peanut powder, but there are other in the guidelines.
Another important point to make is that this study and these guidelines involve the prevention of peanut allergy and not the treatment. So in fact, if a child has been clinically reactive to peanut and found to be reactive to peanut by their doctor, there's no recommendation for feeding to these infants. So we're only talking about infants who are not clinically allergic to peanut to begin with.
And Dr. Baker, I know you mentioned this at the beginning, but I think it's worth repeating because I've had a lot of confusion around this. The infants that were already clinically allergic to peanut were excluded from the LEAP study. So that is very important to know up front. When you've got an infant with a clinical allergy, there is absolutely no recommendation to feed peanuts. Strict avoidance is the only safe route.
So given those caveats, there are guidelines for high risk, medium risk, and low risk, and we'll go through each now. First, for high risk infants, and those are the ones that have egg allergy or eczema or both, the real key again is to introduce an age-appropriate peanut food from 4 to 6 months of age. And first, you have to make sure the child is able to take solid foods, and you probably should do this with another type of food. If the child has egg allergy and eczema or both, it's probably appropriate to bring the child to your pediatrician or allergist office to be evaluated for clinical allergy. And they can do this either with skin testing or blood testing for peanut allergy. And then the doctor and the parents can meet and decide, based on all this information, if it's safe to introduce peanut to the child and what would be the appropriate venue for that, i.e. at home or in the physician's office. And I think in this way, parents and physicians can feel comfortable that they're doing the right thing for these children who have high risk for peanut allergy.
The moderate risk group, those are infants, again, with mild to moderate eczema. And if you're not sure if your infant has mild to moderate eczema, just consult with a healthcare professional, a pediatrician, a dermatologist, an allergist will be able to guide you on this point. The recommendation for infants that fall in this category is to introduce age-appropriate peanut foods around the age of 6 months to reduce the risk of developing peanut allergy. And again, for this group, other solid foods should be introduced first to make sure that the infant is developmentally ready to receive solid foods. And then for this group, peanut may be fed at home without prior evaluation at a doctor's office. However, if you, the parent, are concerned, or if in consultation with your pediatrician, he or she is concerned, the child can certainly undergo a medical evaluation and have the introduction to peanut be supervised by a physician.
Finally, for infants at low risk, it's recommended that parents are free to introduce age-appropriate peanut food based on their family practices and cultural practices. Introduction can be done at home, and obviously the guidelines have an addendum with appropriate foods to do that. And the early introduction in this group actually will help contribute to the overall reduction in peanut allergy, because in the trial, a significant number of children who were at low risk still went on to develop peanut allergy.
So for the guidelines, it's so important to keep in mind which children we're talking about. The advice is segmented into high risk, moderate risk, and low risk. And we need to make sure that we pay attention and follow depending on which of those categories our infant falls in. These guidelines are so crucial to implement because they are the only tool we have right now to prevent peanut allergy, which is among the food allergies, the deadliest of all the food allergies, and can bring significant medical and psychological burdens to families. Now, there are certain misconceptions about the guidelines, which I know we're going to address in the question and answer section, but Dr. Baker, I'm wondering if you want to talk about a few of those misconceptions now.
I think there are three things that we really need to reinforce. Again, these were not written for children that are already allergic to peanut, and introduction in that case is not recommended. I think that it's important that parents don't feel guilty or in some way embarrassed about this. If anyone should be embarrassed, it's the medical community that recommended delayed introduction, because that was done without any hard data. And once we got the hard data, it was clear that that was not the best thing to do. And these studies in the guidelines are based on medical, non-for-profit, and government organizations. These are not in any way industry-sponsored, and in no way are they trying to propagate peanuts. They're just trying to prevent peanut allergy. So I think parents should feel comfortable that there's no conflict of interest involved in this.
And one thing important to note, while we invested in research and science to help give us a chance to improve prevention and stem the tide in the newly diagnosed, we of course continue to invest heavily in research for new treatments for those already diagnosed with food allergy. Additionally, we fund significant education, support, and advocacy programs aimed at making real, measurable differences in the lives of those, like my family, already diagnosed, as well as the communities that support us. Now we can move on to questions and answers.
Well, great. Thank you so much, Jim and Maria. That was a fantastic overview and clarification. So at this time, we're going to be addressing some of the questions that FAIR has received from members of the food allergy community regarding these new guidelines. And please do forgive me if you both have already answered some of these in your presentation, but perhaps it's good to reiterate the answers in light of all of the questions. So if I may begin, we have a handful of questions that fall under the category of perhaps who is at risk. So first off, one of our community members asked, I would like to know how children are categorized as at risk when they are only a few months old.
Well, the factors that they identify are two things that usually occur very early in life. Eczema is a skin condition, an inflammatory skin condition that in genetically susceptible individuals usually occurs at birth. And certainly by 4 months of age, they've seen a pediatrician have been diagnosed with or without eczema very early on. The other thing that people are concerned about is egg allergy, and egg is certainly one of the first foods that is introduced into the diet, even before other solid foods. So most parents know if their child is egg allergic at that age. And the two factors tend to co-segregate together with peanut allergy, so there's a greater risk even if you have both of those things than either of them alone. Eczema alone is a risk factor, even without egg allergy. So these are just general factors that can help guide parents and tell them whether or not they have a greater concern about allergy. I think the important thing to remember is if you have any concern at all about starting food or any type of food with your child, you should see your doctor and talk to them first.
And a very practical point to this, too, is how would you know if your infant is allergic to egg already? Is by having fed them egg and have them have reacted to it. So if you've given them a tiny little bite of scrambled egg and you've noticed some hives, some swelling, some itchiness, even more extreme vomiting or other gastrointestinal discomfort, those symptoms are symptoms or signs of a clinical egg allergy, and that's how you would know that your infant is allergic to egg.
Great, thank you so much. Another community member asked, I'd love clarification on guidelines for a baby or toddler who has tested positive for peanut allergy, but actually has either never ingested peanut or never had an allergic reaction after ingestion.
This is a great question. I'm going to let Dr. Baker answer it, but it also picks up on something we said early on in the presentation. Dr. Baker mentioned clinical food allergy. So I think it's important to explain what that means to have a clinical food allergy, and it ties in perfectly with this question.
This is a very good question because often as part of an initial evaluation, babies are tested for antibodies against peanut and often assumed to be allergic, but in fact, unless they've clinically reacted to peanut, even with antibodies, they aren't allergic. And in fact, in the LEAP study, children that weren't clinically allergic but had antibodies had almost the same reduction in clinical food allergy to peanut as children that didn't have antibodies. So in fact, if your child's tested positive, they would likely have you go to an allergist and do some type of test dose to see whether or not they're allergic, unless the testing was such that the physician felt there was a very high likelihood that they were allergic. So in fact, if your child has this type of situation, I think the best thing you could do is see an allergist to help them sort it out for you.
Great answer. We have one more question kind of in regards to who is at risk, and this person stated that according to her physician, babies in the study were skin tested first. Any baby that had a positive skin test was excluded from the study. So is this a recommendation that all babies see an allergist for a skin test before the introduction of peanuts?
So, no, it is not.
This is an incorrect characterization of the study. The babies were skin tested, but that didn't stratify them as to whether or not they went into the study. As we stated, you really need to evaluate your child individually. If there is any concern, you should go to an allergist. But in all the, even children who had a positive skin test but weren't clinically allergic were entered into the study. So I think the physician might have been confused about actually how this was set up.
And like it or not, unfortunately, allergy testing is still an art and not a full science. So for skin testing, if you haven't undergone it before, the results are the measurement of what they call a wheal size. So the skin will react and you will get a certain size wheal, which the physician will measure. The larger the wheal, the more likeliness of having a clinical food allergy. So some babies actually did have a positive skin test, but with a small enough size wheal that they were still included in the study.
Great, thank you. I think kind of moving on from that category, we did have a couple questions that were about breastfeeding. I know, Maria, you were talking a little bit about the inquiring about tolerance study, and perhaps that focused more on the infants and if they were breastfed or not. But we had some questions coming in that were geared more towards the mother that perhaps maybe either of you could answer. One of them asked if in the future, will there be guidelines coming out to address whether to eat peanut products during pregnancy and while breastfeeding?
So we don't have any studies that go to this with breastfeeding parents, but I think it's safe to say, given that our recommendations now are to not delay introduction of this food, the same would hold for a breastfeeding mother. So if you regularly eat peanut and you are breastfeeding, there's no reason to change your diet. If you, for some reason, avoid peanut yourself as a mother, you can retain those preferences as you wish. This also doesn't go as far as to say breastfeeding mothers should eat peanut.
Yes, there's no data at all that suggests that the mother eating these foods induces tolerance in the children. The children in these studies were fed the food directly. So as Maria alluded to, there's no evidence that breastfeeding has any effect on this. And clearly, the one thing we know now is that early feeding does not cause an increase in food allergies. So in fact, I think parents can be comfortable with that in general.
That's great. That's a great point to mention. I had a question come in about kind of what you do in your household, and someone was asking how you would be able to safely introduce allergens when you have other children in the house who are severely allergic. Are there any tips or recommendations for that?
You know, this is a very personal question to each family on how you safely manage food allergens. So in my household, for example, my oldest daughter is allergic to peanuts, and we don't like to have peanuts in the house. If I were to have a young baby infant in my household now, I would find a way to safely introduce peanut with, you know, common sense approaches. The peanut is not going to jump out and get my older daughter, right? So if we take common sense approaches of keeping hands, keeping cooking surfaces and utensils clean, wash through the dishwasher, then there should be no problem in feeding one child in the family a food that another child is allergic to.
It might be easy to think of the food, the peanut, as a drug. You know, taking the same type of precautions you would take with one child's medicine so another child doesn't get a hold of it, and making sure that everything's cleaned up afterwards. You know, sometimes if the older child's in school, you might try feeding while the child's away from the house in school or in daycare. So there are ways to do this, and we agree it's you know, it can be a daunting task, especially with a large family, but you know, it's important enough to do that I think recommendations and approaches are available.
Great. Yeah, I know some of the online community members did chime in that some of the advice does seem a little scary, and I'm sure you would both recommend that perhaps you would want to have epinephrine on hand just in case there was a reaction if a different child in the house did have a food allergy.
Well, like always, with any child who's allergic, you've got to have epinephrine on hand, whether you have it, introduce it in the household or not. And then the second point is we really have to go back to those 3 risk categories and make sure you tailor the advice to the risk category. It is not the advice that you should introduce peanut early, 4 to 6 months of age, for all infants. That is the advice for those that are in the high-risk category, severe eczema and or egg allergy. So we need to make sure we don't generalize to the entire population what is very specifically segmented to different risk groups.
Right.
Yes, the epinephrine would be for the individuals who are clinically allergic. The child who's not allergic and eating the peanut should have no problem. I mean, that's the remarkable thing here, that the reduction was so tremendous.
Wonderful. Thank you for clarifying that. I think this study kind of sparked questions about additional studies or future studies that people were questioning about. So if I may ask a couple questions around that topic. One of our community members stated that they are so happy that they are finding solutions for kids to not develop this allergy. However, they were curious what studies are being conducted for kids and teens that already have this allergy. This individual has already read a few things, but perhaps nothing seems quite promising yet.
Well, the real issue right now is developing therapies for these young people. And there are 2 drugs that are specifically in development for peanut allergy. One, the patch by DBV, the other one, oral immunotherapy by AIM-Immune. But yeah, when you're introducing something like peanut into allergic children, you need to be very careful. So these studies will take a long time. We're hoping that within the next couple of years, something will come out that will be an appropriate treatment, at least for some of the children who are peanut allergic. But this has nothing to do with prevention, and certainly we understand your frustration. This is a very difficult thing to manage.
Great, thank you so much. Another person mentioned a different study that was taking place, and they said before publishing recommendations, such as eat this at this time, are there any long-term studies that look over the span of several decades on these particular recommendations? And also, are there subjects of multiple races, ethnicities, and gender?
So this is a very good question. I think the question answer is comparing this to the Framingham heart study that took several decades to conduct. In fact, for food allergy, the LEAP study is the Framingham heart study. And the reason for that is heart disease takes many decades to develop, so you have to do it over 40 or 50 years. Peanut allergy develops essentially in the first 4 to 5 years of life. So in fact, we've already looked at the entire developmental scheme for peanut allergy with the LEAP study, and it in fact is very comparable to the type of data that we got out of the Framingham heart study. The other thing that's very nice is there were multiple races, ethnicities, and genders involved in the LEAP study, and the investigators have broken down their analysis by race and gender and ethnicity and shown that all of those groups, regardless of their race, regardless of their ethnicity, had equal responses to early feeding of peanut. So this is broadly applicable no matter what your race or gender or ethnicity.
Wonderful. Thank you so much. I think now we'll move on to a couple questions came in about perhaps some of the long-term effects related to this study. They asked if either of you could please address how this may not work for every child. Some children may still develop an allergy, as many parents will attest to with their own experiences.
This is such an important point because if you look at the results of the LEAP study, it wasn't that 0% of the kids developed peanut allergy. What we saw was that there was a reduction of 81% in the incidence of this condition for those that were exposed to peanut, but there were still not insignificant number of kids that developed the allergy, even in the group that were fed peanuts. So yes, this is not going to work for all. This isn't the panacea answer to eliminating peanut allergy, but it is a big step in that direction, especially since we have a condition that once developed, we don't have an effective cure or treatment from at this point. So we look at it from two angles. We've got prevention and we're working on cure and treatment. But while we don't have the cure and treatment ready to go, something that we can do to prevent more kids from developing this allergy is a big step forward.
Great, thank you. One of our members asked, a good question, which I think a lot of people are thinking, and it kind of is around the word trust. They questioned, how can we trust these recommendations when scientists still don't know the root cause of peanut allergy?
Well, it's clear that we don't know the root cause of peanut allergy. It's probably multifactorial. There are probably a lot of things that play into it. The real key here is that it's broad scale, lots of children, and it's prospective. So in fact, you look at the child as they normally develop to see whether or not they develop the allergy. So in some ways, this is very powerful because it doesn't look at subgroups or kids with certain types of backgrounds or kids with certain types of skin reactivity. It looked at all children, and it actually showed that it was broadly useful for all of them. So in fact, these studies really validate the concept, and parents should be very comfortable that what they're seeing is actually a benefit to their child and not some type of experiment.
And also, unlike the 2008 recommendations to avoid early introduction, this recommendation is based on hard data, which you can go online and look at. There were almost 600 kids, infants, enrolled in this study, and they were followed for over 5 years. So this is based on very good data.
Great, thank you so much. We have just one last question, or perhaps it's more of a comment or a statement. This person wrote that information like this causes people to judge those of us who have kids with food allergies. Every time one of these reports come out, I have people telling me, oh, you should have just given him peanut butter earlier. My kids show that all of these early introduction studies are not the full answer.
Well, I couldn't agree with that sentiment more, in the sense that it is certainly not the full answer. It is a sliver of this puzzle, an important sliver for those that don't yet have the clinical food allergy. But as a mom who did at some point what was considered everything wrong, so I ate peanuts while I was breastfeeding, and for a while I felt guilty about that. Then I thought about whether or not I avoided, peanuts in my infant, and now I'm thinking, gosh, I shouldn't have avoided at all. We can only do the best we can do with the information we have at the time. And that goes for anything in parenting, right? So for the people that come out with these judgments, I know it's hard to take sometimes, but maybe try to turn it into an educational moment for them on what we do know about food allergies. But I feel your pain on this one for sure.
And importantly, we have to publicize this. The impact for future generations is so important that it's not something that we can hold back because there are ignorant people out there that say things like that. So I feel badly for people. As I said, if anyone should be embarrassed, it should be the physician population who suggests that we should hold back without data. But we need to be strong, and we need to move forward, and we need to do the things that may prevent peanut allergy in thousands and hundreds of thousands of children in the future.
Great. Thank you so much, Jim and Maria. And just a quick thank you to our food allergy community for asking such insightful and thoughtful and engaging questions. Again, I'd like to once again give a special thanks to Dr. Baker and Maria Acebal for providing some really valuable background information about the NIAID updated guidelines and for answering so many of the questions that our community members have had about these guidelines. It was a pleasure to have you both with us today. Thank you, and until next time.